meningitis. Idiopathic, again guys, if you see that, it just means that we don't know exactly why. Like there's no identified cause. It's just an increase in intracranial pressure that we are not sure why. Meningitis is subarachnoid hemorrhage. So if you're using the ophthalmoscope and you look at the optic disc and you have blurred margins, okay, you don't see those sharp margins from the optic disc. Usually means that there's swelling of the optic nerve head, and it can mean any of these pathologies. Okay, this is a grade 2 papilledema. Look at your optic disc head. If you looked at the other picture, you see your margins are nice and sharp. It's a nice round area. Look at this, your margins are nice and blurred out. If it's a higher grade, you'll see less and less margins. Okay. Optic disc cupping. When you see optic disc cupping like this, usually you want to think of glaucoma. Okay. Optic disc cupping will usually because there's an increase in intraocular pressure. I'm sorry. Optic disc cupping is associated with glaucoma. Guzman's rubs, you can actually look at retinal background abnormalities on this page. I'll let you look at it at your own. Hypertension, hallmark of malignant hypertension of retinal edema, flame-shaped hemorrhages, and large exudate. This is what it usually looks like. On your exam, I usually put a picture of this. I'll give you a scenario of someone with a very high blood pressure and a very high blood sugar. You know that I am talking about flame-shaped hemorrhages or cotton wool spots. You see these in hypertensive emergencies or hypertensive retinopathy and diabetic retinopathy. The cotton wool spots you see more in diabetic retinopathy. You see the AV nicking in hypertensive retinopathy and diabetic retinopathy. Hemorrhage, flame-shaped hemorrhages, and your macular star, you see those in your hypertensive retinopathy. Okay. So look at your normal retina, look at your diabetic retinopathy. Okay, this is why they end up with so much blindness and all this stuff. Neovascularization, you have microaneurysms and edema and exudates in the eye, cotton wool spots all over. This is your diabetic retinopathy. Your flame-shaped hemorrhages, cotton wool spots. Usually you have some kind of vascular abnormality, hypertensive, diabetic. Okay? These are what we call vascular paths. Yes, I love this. Hyperopia versus myopia, we know exactly what this is. We talked about it. See, I told you guys, we have a whole lot of these things that are repeated. And we talked about this already. Cholinergics and anticholinergics. We talked about this. We talked about the direct response and consensual response. We said which cranial nerve observes the light reflex? 2. Which cranial nerve constricts the pupil?
3.
Okay, they work very well together. All right. Convergence or accommodation, you're looking at cranial nerve 3, because remember cranial nerve 3 constricts the pupils, and then the eyes converge. Pupillary size, meiosis, small pupil, you're thinking of a patient with who are bilateral meiosis, you're thinking they're using opioids, they had some heroin overdose, or something like that, or they can have a brainstem lesion, especially a lesion in the pons. Mydriasis, a large pupil, they're taking a sympathomimetic. Meiosis can actually come from a cholinergic drug also. Remember, cholinergics constrict the pupil, sympathomimetics dilate the pupils. Cholinergic constricts the pupil because it says now it's time to rest and digest. The sympathomimetics or the sympathetic nervous system dilates the pupil because it says I need to see what danger is ahead of me. The pupils dilated, mydriasis, cocaine, or any sympathomimetic drug. Okay, anisocoria. Anisocoria can be actually a normal or benign finding. It just means one pupil is smaller than the other. Okay, it can be a normal variant, or it can be associated with Horner syndrome. Horner syndrome is basically a dysfunction of the sympathomimetic innervation of the eye. So you usually have one pupil that's actually larger than the other, and that's what the anisocoria is. Ptosis is drooping of the eyelid. Remember, cranial nerve 7 closes the eye, cranial nerve 3 opens the eye. If cranial nerve 3 is not working, the eye is closed. If cranial nerve 7 is not working, the eye is open. Okay. Horner syndrome, again, you have the meiosis in one eye and the other eye is normal. Anisocoria, one pupil is smaller than the other. Okay. Horner syndrome, meiosis, ptosis, and anhydriosis. Anhydriosis is basically. I did?
You did.
Good job. Getting tired. So meiosis, ptosis, and anhydriosis is basically one eye, they don't sweat over one eye.
Right.
Okay. The ptosis, you have the lid drooping, and the meiosis is basically one pupil is the very small. Okay. Again, it can result from a lesion anywhere along the sympathomimetic innervation of the pupil. They call it an ocular sympathomimetic paresis, and that's, you don't have to remember that. Don't give me that face. But somebody tells you that, you know what they're talking about. That's all it is. It can be very benign, and it can actually be a serious condition due to brain stem function. It can be due to traumatic brain injury. It differs for children or adults, and this is basically mnemonic to remember Horner syndrome. Again, sympathetic nerve fiber injury, anhydriosis, meiosis, ptosis, loss of ciliary spinal reflex. That's why you have one pupil bigger than the other, and enophthalmos, which means the eye is sunken back. Jesus, all these words are new. These are the etiologies of Horner syndrome. You don't have to remember that, but I just put it in there just in case you wanted to, just because, you know, you might be curious, and you just want to know. So, when you're looking at extraocular movements, conjugate means that they move together, okay? If you are looking at any question and they say ipsilateral, it means same side. If they say conjugate, it means that it moves together. Contralateral means opposite sides. Nystagmus, we talked about that already. This conjugate, you'll see that when we talk about cranial nerves 3, 4, and 6, extraocular movement. If one eye is out and the others are moving and that one can't move and it lays out, that's a disconjugate gaze, meaning the eyes are not moving together. So if someone has a disconjugate gaze, it usually means they have a cranial nerve palsy. It's usually 3, 4, or 6, one of them. That's when they have this disconjugate gaze. So usually, say I'm looking forward and my eyes are coming forward and this eye is laying out. I have a disconjugate gaze because both of my eyes are supposed to follow and go in the same path, okay? Some kids can have a disconjugate gaze in a developmental abnormality, and usually what they do is kind of cover the eye, the weaker eye, so it can actually auto-correct itself. And adults usually cranial nerve injury. Sclerotomas and vitreous floaters, I don't know why I have them both, twice. I get a little crazy sometimes. We talked about these already. Glaucoma. We have open angle and closed angle. Which one do you think is the worst?
Close.
Okay. Open angle is usually slow and progressive. Remember, the canal of Schramm is usually blocked off. No circulation of your aqueous humor, and it can build up pressure in the eye. It can lead to blindness. Usually what happens in these patients, peripheral vision is gone, central vision is preserved. Okay? They're opposite of macular degeneration. Okay. We talked about this. See? All the peripheral vision is gone, and they can just see in the middle. early glaucoma, normal vision, advanced glaucoma, and then extreme glaucoma. Tonometry. Tonometry is what we usually use to measure intraocular pressure. Tonometry normal range, 10 to 21. Anything greater than 21 means that there's increased intraocular pressure. Usually means that we have some kind of glaucoma or something going on with this patient. If you have a patient with a tonometry of 22, it is elevated. Remember 10 to 21. Okay? 10 to 21, normal. Okay? Cupping, remember intraocular pressure that is increased can result in cupping. Okay? We talked about, what do you call it? Blurring of the margins with increased intracranial pressure. Intraocular pressure, you're thinking about cupping, okay? That you see with glaucoma. Primary open-angle glaucoma is usually progressive, slow. Closed-angle glaucoma is usually rapid, and it can actually progress to blindness really fast. It is an emergency, okay? Open-angle chronic tends to progress. Blacks are about higher risk, so you want to assess them. Everybody now smokes marijuana for their glaucoma, whether they have it or not. I was in a cabbie in San Francisco, and the guy, like, we got into the Uber, and I was like, oh, holy hell. It was like, we were like, he was smoking the weed right there. It's just like he had all the windows down, and he's driving like a madman, and we were like, oh, we're gonna die. We're so gonna die. We're so gonna die. And then we came out, I was like, I'm sure he's telling people he's got glaucoma. He has no damn glaucoma.
First of all, why is he driving? He has to drive glaucoma, right?
Huh? Exactly who you want driving your Uber. Okay? But we didn't want to tell him stop and let's get out, because we're like, oh, this guy's gonna go crazy on us and flip. So we're just gonna take it easy, put our heads out the window, and hope that we don't smell like weed when we get out of this car. Okay? Huh? I don't know. I don't know what the mechanism of action is, honestly, God. Huh?
It just relaxes you from not being able to see?
I guess. I guess, but apparently there is some medicinal value for marijuana and glaucoma. I don't know what it is, but there is. Okay. Giant cell temporal arteritis, we talked about this. It's an inflammation of the temporal artery that's usually associated with headaches. It's usually older people, and usually what they come in with is headache. It's usually unilateral, and it's a throbbing type headache also. And usually what they have is systemic symptoms. So they'll tell you they're fatigued and tired. I just don't feel well. I don't know what's going on. It's associated with this headache. You do a temporal artery biopsy. Usually what they do is an ESR first of all, and the ESR is usually elevated, which can prompt you to do a temporal artery biopsy, which can prompt treatment. Okay. Amaurosis fugax, ipsilateral monocular blindness. Ipsilateral, same side as the carotid that is occluded. Ipsilateral monocular, one eye. One ocular eye. Ipsi, same side. So if I have a right carotid occlusion, I have a right eye that I transiently lose vision in. Ipsilateral monocular blindness. And it usually means that a stroke is on the way. Okay? That's exactly what it means. It's a stroke is on the way. You either go and fix that carotid, or that person's going to stroke. Okay? Amaurosis fugax. Okay? Your patient describes blurred vision as well as halos and glares, response of bright lights, or when driving in the dark. There's no pain. This is a cataract. Okay? Alright? You're assessing, you're going to ask these kind of questions. Blurring vision, halos, can't see in the dark. Okay. Blepharitis, conjunctivitis, we talked about already. Subconjunctival hemorrhage, we talked about already. See, I told you guys, we skipped a whole lot of slides. How much more do we have? Not that much.
Only 95.
That's a lie. We just did a whole lot more than 95. Don't listen, I'm not even paying attention to her. The ear. Auditory canal. We have the external and internal. The internal, the lamprey is your internal, which is basically that part that's usually connected to neural tissue. Okay? The external part of the ear, the outer ear, your external canal. Your cochlear is a part of the inner ear. The semicircular canal is a part of the inner ear. Okay? You tympanic membrane. This is your normal tympanic membrane. This is what the normal tympanic membrane looks like. It's a pinkish pearly gray. Okay? You do not have to know these. The pars placida. You don't have to know this. Lateral process of Malleus or pars tensa. You don't have to know that. But Dr. Abuha would like you to know where the cone of light is.
What?
Remember, you have to know which eye you're looking at. I mean, the ear you're looking at. So, if you say the cone of light is at 7 o'clock and you're looking at the right ear, you're wrong. We know you're not seeing it. Okay? Know which ear you're looking at. So I know you're nervous when you're testing, and you may think your left is your right. So to be on the safe side, just go, I see the cone of light, it's at 5 o'clock. Is this your right ear? Yeah, and it's my right ear. Yes, it's at 5 o'clock. Okay? Make sure you know which ear you're talking about. It's at 7 o'clock, it's your left ear. Okay? 5 o'clock, right, 7 o'clock, left. Okay? And the cone of light, you just basically all you see is a shiny thing. And if you don't see the cone of light, just know what ear you're not looking at and say the cone of light is at 7 o'clock, it's to the left. Okay? Nobody knows if you're seeing it.
Not even the patient.
Not even the patient. Hearing loss. Sensory neuronal versus conductive hearing loss. This is where your tuning fork comes in. Your tuning fork is your key to distinguish whether there is sensory neuronal hearing loss or conductive hearing loss. Okay? You're going to strike the tuning fork. You're going to test for Weber. When I test Weber, I'm going to put it in the middle of her head, and I'm going to tell me if you hear it equally on both sides. If she hears it more in the left ear, then I'm suspicious. There is some type of hearing loss. I can't deduce what type of hearing loss it is at this point, because it could be that she has a sensory neuronal hearing loss and it's actually gravitating to the good ear. Or it could be a conductive hearing loss and the sound is lateralizing to the bad ear. If it's a conductive hearing loss, with Weber, the sound is going to lateralize to the bad ear. If it's a sensory neuronal hearing loss, with Weber, the sound is going to lateralize to the good ear. Does that make sense? I'm going to do it again. Oh no, I hear it more on the left. I don't really hear it on the right. Okay. That either means that she has a conductive hearing loss on the left, or she has a sensory neuronal hearing loss on the right. Because with conductive hearing loss, the sound is going to lateralize to the bad ear. And with sensory neuronal hearing loss, the sound is going to lateralize to the good ear. Now when I do Rinne, that's going to deduce it for me. So then I go, after Weber, then I'm going to do Rinne. I'm going to take it, tap it, and put it on her mastoid process, and I'm going to say, tell me when you stop hearing it. Okay? Air conduction, when I put it in front, you never strike the tuning fork twice. You strike the tuning fork only once. You're going to put it on the mastoid process. You're going to say, tell me when you stop hearing it. Once she stops hearing it, then you're going to put it in front, and you're going to say, tell me when you stop hearing it. Okay? Air conduction should be twice as long as bone conduction. If bone conduction is longer in the left ear and the sound lateralized on Weber to the left ear, that means she has a conductive hearing loss in the left ear. I'm going to say it again. One more time. Weber. Dr. Morton, I hear it better in the left ear. Okay. Rinne. Ooh, it's there for a long time, 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 a long time. And then I put it in front and she says, oh, I don't hear it. So with Weber, it lateralized to the left ear.
That means the
And
left ear
then-
is good, right?
No, it depends on
Okay.
which hearing loss it is, whether it's conductive or sensory neuronal. So when I do Rinne now, and bone conduction is longer than ear conduction, I know that it lateralized to the left ear because the left ear is the bad ear.
Okay.
Because with conductive hearing loss,
Mhm.
it's going to lateralize to the bad ear, and then bone conduction will be longer than
Under the
ear
air
conduction.
Okay.
So if the air was twice as long, would you be able to, like, the right ear is
Exactly,
the problem?
exactly.
Would you have to do more tests on the right ear, or you would just be able to?
You can do more tests. They will do more tests and learn.
Almost came to an end, but I heard the air line. It's amazing, you can really hear it.
So if I do this, and she says, oh, I hear it better in the left ear, Dr. Morton.
Okay.
And then I do this, and bone conduction is fine, and ear conduction
Wow.
is twice as long, then I know
It's the
that
right.
the right ear is probably a problem. And she has a sensory neuronal hearing loss
Okay.
in the right ear.
Okay.
Because with sensory neuronal hearing loss, it's gonna lateralize to the good ear. Okay? And then ear conduction will be twice as long as bone conduction. With conductive hearing loss, it's gonna lateralize to the bad ear, and bone conduction is gonna be twice as long as ear conduction. Does that make sense to everybody? Yes? 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 I drill it in your head because then when on the test you go, huh? Which one is it? Ear conduction or bone? Okay. Conductive. The reason why conductive hearing loss is actually you hear it better is because usually it's conducting off of something. There's something in the external ear canal that the sound is bouncing off of. So if your 5-year-old sticks a bead in his ear and is not hearing in school, and I go and I do it, bone conduction is going to be longer than ear conduction, and the sound will be bouncing off that bead that he stuck in his ear. Okay, that's an obstructive. That's usually why you get the conductive hearing loss. Does that make sense? Or I have a big rock of cerumen in my ear, in the external ear canal, and it's like it's been there for so long, it's like a rock. I have decreased hearing, and I do it, and bone conduction is longer than ear conduction, and it lateralizes to that ear. That's conductive hearing loss. The sound is bouncing off of whatever is stuck there. Does that make sense, guys?
When it goes to the other ear, and it's twice as long in the ear, then it's sensory neural.
Exactly. Okay. Sensory neuronal, the sound will lateralize to the good ear. Conductive, the sound will lateralize to the bad ear. Sensory neuronal, ear conduction and bone conduction. Ear conduction will be longer than bone conduction. Okay? Or you just won't hear it in the bad ear. With conductive, bone conduction is much longer than ear conduction. So you have to first ascertain which ear it lateralizes to, and is it bone conduction longer than ear conduction. If bone conduction for any reason is longer than ear conduction,
It's conductive.
you know it's conductive.
Conductive.
Okay? Does that make sense?
This is a stupid question, but if you're doing bone conduction and it's longer than air conduction, you're doing the bone first, right?
Yes.
And when you come out, they wouldn't hear anything at all.
No, you do hear it.
Oh, I get it. It's just a time frame. So if it's 30 seconds here and it's 20 seconds air conduction, then
Yeah, then you know it's bone conduction is longer.
okay.
Okay, because you do it. I'm gonna give you an example. I mean, it's people are like, no, I can't believe that, but it actually works. So you can stop hearing it.
Mhm. Yeah. That's,
Much louder, right? Yeah. So it should be much more intense with the air conduction, and it's longer. You hear it for much longer duration, twice as long. Okay, guys, everybody's good? No questions on that? Hearing loss, sensory neuronal. If I'm in a loud room, I can't hear anything. They look like they're just doing this. Conductive, because again, sound bounces off of whatever is there. Loud environments, they hear better. So these are the people that you go to their house and the TV is like blasting, blaring. Okay? Conductive. Tinnitus. Tinnitus can come from a whole lot of things. Hearing loss, vertigo, meds. One we like to give a lot, furosemide. Okay? Furosemide is one of the #1 things to cause the tinnitus. Okay? Some of our antibiotics, I think Vanco is one of them, and can give you tinnitus. Okay?
Is Meniere's disease degenerative?
I think it can be
Yes.
progressive.
There's
Yes.
there's a man in my church that had that and that ended up now with a cochlear implant.
Oh yeah.
my mom went deaf from it. She ended up having really bad nausea, vomiting, vertigo, really bad for
And then
years.
Terrible.
And then she finally went deaf in that year,
Okay.
and then she's fine.
Oh, they put the
No,
they didn't
she
do
doesn't
anything.
do anything.
As long as it
She's fine with it.
Oh, but she lost hearing.
Yeah,
Like,
she lost
in
it.
one ear. Okay, vertigo. Sensation that the environment is spinning. Cranial nerve 8. Labyrinth problems. Okay? Or central nerve lesion. A schwannoma. It's a tumor of cranial nerve 8 that can actually give you these kind of things.
Labyrinthitis?
It gives you, labyrinthitis will give you the sensation of spinning. Am I going backwards? Feel like it. Yeah.
No.
Oh, I had that
You just
slide
went over
twice.
that.
Look at this. I know. All right,
Were you wearing your green contacts?
now, I'm smarter now. Okay, Weber, lateralization of the unilateral conductive hearing loss, sound lateralizes to the impaired ear. In unilateral sensory neuronal hearing loss, sound lateralizes to the good ear. Everything I said. Weber, put it in the middle, conductive hearing loss, ipsilateral side, hearing deficit, sensory neuronal, good ear. Rinne, bone conduction should be less than ear conduction. Ear conduction should be twice as long as bone conduction. Okay? All right. Are we good on those two guys?
Yeah.
Alright. This is the same thing. I put it there like multiple times because this confuses people so much that it just needs you to understand it completely. So go home, look at this again, okay? And ask me questions next week if you need to. But just look at it again and make sure you can isolate it in your brain. Because when I give you that question, you're gonna be like,
Can you give us an example?
yeah, I did. Kimberly comes to the clinic, complaining of hearing issues. You perform a Weber test, and when you perform the Weber test, she tells you that she hears the sound greater in her right ear. You perform a Rinne test, and bone conduction in the right ear is twice as long as air conduction. You deduce that this is conductive hearing loss. Look at that. Test did do the same thing. I have that already. Ooh, look at that. So possible causes: cerumen impaction, cholesteromia, osteosclerosis, external ear tumors, tympanic membrane rupture, severe otitis media, things in the ear can be sensory neuronal, labyrinthitis, Meniere's disease, acoustic neuroma, okay, acoustic neuroma or schwannoma, ototoxic drugs, aminoglycosides are one of them. Use of the otoscope, we know how to use it, the pencil hole versus the hammer hole. You guys are good on that? You guys go to the lab, you're good on that, guys?
Yes.
Pencil hole versus hammer hole, right?
Mhm.
Remember, where does your hand go?
Against the
Against the head if it's a hammer hole, against
Against
the
the
cheek.
cheek.
Where's the top of this ophthalmoscope go? Towards the nose. Okay, or towards the head. Should never go back, and it should never go down. Okay? Ototoxic drugs, aspirin overdose will give you some serious ototoxic issues. Tinnitus. Quinine, we don't use it so much anymore, it's a TB drug. We also use it for arrhythmias, okay? NSAIDs, furosemide. Okay. You guys don't have to know this was a differential diagnosis thing, so you don't have to know this, but, it's good to know for your differential diagnosis courses, you're gonna have to know it. Okay. All right, vertigo, central versus peripheral. Benign positional vertigo is a peripheral vertigo. You have to ask questions like, is there weakness on one side of the body? Okay? Is there any other changes? Do they have a facial droop? Do they have any diplopia? Okay? Central, you're looking for strokes or intracranial lesions. Peripheral, it can be anything from a benign positional vertigo, a labyrinthitis, or Meniere's disease. How do you diagnose benign positional vertigo? Dix-Hallpike maneuver. Usually what they do is you're gonna take the person, put them on the bed, and put them so that their head can hang off the edge of the bed when you put them down. You're gonna swiftly put them down and turn their head to one side. Usually what happens is that increases the dizziness, and it can actually cause intense vomiting, so don't stand close to them. And oscillation of the eyes, so they usually have nystagmus. The one thing you need to remember, benign positional vertigo, the nystagmus is fatiguing. That means it comes to an end. If it's something in the brain, the nystagmus is non-fatiguing. That means it doesn't come to an end. Okay? So if you do this, and you induce the symptoms, and then the nystagmus starts, and it continues and 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 brain, it's probably the brain stem. But if it stops and fatigues, it's probably a benign issue, a peripheral issue. Make sense? Epley's maneuver, benign positional vertigo, it's usually the crystals in their ear canal that is loose. So usually they do Epley's maneuver, and they usually do, the occupational therapist will do a whole bunch of spinning and turning of the head, and it actually resettles those crystals in the ear canal, and actually settles and completely
Makes it better.
decreases or makes it better.
Is that what they call vestibular therapy?
Yes.
Okay.
Stress cosa, I have that last week.
You just had Epley's maneuver?
No, the vertigo in the morning. I woke up dizzy. I was like all day dizzy. I couldn't even
Really?
think.
That's your brain. Oh no, that's nystagmus.
That's the standard. Meniere's disease, the benign positional vertigo, they do not have tinnitus. Meniere's disease, they have tinnitus. Okay, so you want to remember that. Okay, it's unilateral most of the times. It can become bilateral. Management, you don't really have to know, but high salt diet or low salt diet is what you usually do. You want to avoid high salt. They can do diuretic therapy, all these things to decrease otitis media, inflammation, so you wanna look at the ear. If it's red and angry, you're thinking there's an inflammation. You don't have to go through the otitis medias because apparently I'm teaching you guys too much. So I have to like not go through the disease processes with you. The whatchamacallit, sinuses. Your frontal sinuses, your maxillary sinuses, sinus pain and pressure. I bend my head forward and it feels like this pulsating pain in my face. Usually it's from sinus pressure, okay? You can palpate the sinuses or you can illuminate the sinuses. If I shine a light, I put the light on your sinus, on your orbital sinus or your maxillary sinus. If your sinus is completely full, you will not see the light illuminate. If the sinus is not full, the light will illuminate through. It's transillumination. Ethmoid, superior, turbinate, middle turbinate, inferior turbinate, maxillary sinuses, frontal sinuses. These are all the things that you palpate for sinusitis. Cranial nerve 1 is your sense of smell. Okay, it's olfactory. It is sensory only. How do you test it? Introduce a familiar smell and have the patient identify it with their eyes closed. Remember, we're not testing for cranial nerve 1 during the health assessment exam, but you're going to say, if I were to test it, I will introduce a familiar smell with your eyes closed and have you identify that smell.
We just do it auto then?
I'm sorry?
I'm sorry, can we just do it auto then?
You can. Tell them to close their eyes. I'm testing cranial nerve 1. You can do that. I see you want to do a whole lot of things. It's only 30 minutes, I hope you know. So, you don't have to do it, but if you want to do it, you can, okay? I can teach you about sinusitis. Assessing the mouth, lips, you want to check for the color. Blue lips is a bad thing. Somebody's lips are blue and they don't have a lipstick, or they didn't just have grape juice, that's a bad thing, okay? They shouldn't be blue. It should be nice and pink and it should be moist. Breath and odor is a problem because halitosis can indicate that there is some type of cancerous lesions in the mouth. So you want to look at the mucomucosa. Leukoplakia or erythroplakia leukoplakia is this white thing over the tongue. Erythroplakia is this red blotches on the tongue and the oral mucosa. And these are precancerous lesions. They're non-painful, they can be benign, but most of them are precancerous. So you want to look for those things. The gums, you want to look for inflammation, bleeding gums. Oral hygiene, how often they go to the dentist. Remember, this is in your mouth and your brain is right there. If it's infected in your mouth, your brain can get infected too. So looking at the soft palate is cranial nerve 9. R is your vagus, and that's actually phonation. You're looking at phonation. Cranial nerve 12 is hypoglossal. That is tongue movement. Usually, cranial nerve 12 palsy, you see that a lot of times when you have a carotid endarterectomy. They actually have to peripherally retract cranial nerve 12 when they do a carotid endarterectomy. So sometimes patients have like tongue abnormalities after carotid endarterectomy. That's just food for thought. You don't have to do that. Okay. And looking at the tonsils and the pharynx, are the tonsils touching? This will tell you if there's a pharyngitis, strep pharyngitis, or anything like that. Okay. Dentition, do they have good dentition? Do they have any ulcerations? Look at the hypoglossal, can they say ah? Do they have good phonation? Okay. Hoarseness, greater than 2 weeks, you want to be worried about it. Things that can cause hoarseness, hypothyroidism, reflux can do it, vocal cord nodules, Parkinson's disease, they can get hoarse because they do decrease phonation. ALS and myasthenia gravis can end up with these. Ophthalmos ulcers, these are usually benign. ulcers that are in the mouth that usually are non-painful and benign and can go away. Oral candida, this is definitely fungal. And usually immunosuppressed people who have this, so cancer patient, HIV patient, usually patients like that. Leukoplakia and erythroplakia. Leuko, white, erythro, red. So if I give you a red blotch, you know it's erythroplakia. If I give you a white blotch, you know it's leukoplakia, right? Leuk, eryth, red blood. Leuk, white blood. Got it?
Yes, ma'am.
Strep. We have strep and strep pharyngitis. Remember, when you're looking at strep, you have to do the center criteria. When you're assessing a patient who comes in with strep, not all patients with strep need treatment. You have to do the center score. The center criteria is right here, okay? The higher, the amount of points they get, the worse it is, and the more treatment they desire. If they have a cough, you minus a point. If they don't have a cough, you give them a point. So if they come in with sore throat and they have no cough, they get a point. If they have cervical lymph nodes that are swollen and tender, they get a point. If they have an elevated temperature, they get a point. If you open their mouth and you see some pus on their tonsils, they get a point. If they're between the ages of 3 and 14, they get a point. 15 to 44, they don't get a point. And if they're greater than 44, you minus a point. Okay? Center criteria. I need you to remember that a patient at 4 or greater, you have to start empirics. You're gonna swab them and you're gonna start empirics. If a patient has a center criteria score of 1, the likelihood that they have group A beta hemolytic strep pharyngitis is 5 to 10%. They don't even recommend a throat culture, but if the person insists, you can do a throat culture or a rapid strep swab. Okay. If the rapid strep test comes back positive, then you can treat with antibiotics. But you don't treat with antibiotics until you get the result. The only time you treat with antibiotics before the result is if they have a center score of 4 or greater.
So if they're coughing, that means they don't have strep.
Exactly.
Okay.
Alright. That's what it looks like. I've never seen anybody with their tonsils look like that, but yeah, good picture. Suppurative usually means that there's pus involved, okay? Bacteremia, lymphadenitis, endocarditis, all these things can result from strep pharyngitis, so you've gotta be careful. Okay? Non-suppurative complications, post-streptococcal glomerulonephritis. Usually these patients go into renal failure for a short period of time as a reaction from the strep. And rheumatic fever, you get a murmur. Neck inspection, the thyroid, your spinal accessory, remember cranial nerve 11. I'm checking your trapezius strength, your sternocleidomastoid strength, and your trapezius strength. So if I take my hand and tell you to push your face against my hand, that's sternocleidomastoid. If I tell you to shrug your shoulders up against my hand, that's trapezius strength. Okay. Checking your thyroid gland, we talked about this last week. Remember your anterior or posterior approach? Posterior approach, you're gonna actually go the back of the person, you're gonna put both hands, you're gonna ask them to swallow, you're gonna see the thyroid, you're gonna feel the thyroid elevate up. If you don't feel it, you're gonna reposition your hands and have them swallow again. You're gonna actually tell them to put their head down and in, push on it, and palpate. Turn your head down and in, push on it, and palpate. Palpate, okay? All right? trachea at midline. Anterior approach, you're using these two fingers. Posterior approach, you're using both hands. Anterior approach, you're using 2 fingers. Okay?
Do we have to do both for the?
No, one
either
or the other.
Okay.
Okay? All right. You need to know that. We talked about the thyroid gland. Triangles of the neck, you don't have to know. The lymph nodes that we have to know. Anybody gonna sit in with me? You guys should know them already. Guess what?
Yes.
Pre-auricular, post-auricular, occipital, jugular digastric or tonsillar, submandibular, submental, superficial cervical, posterior cervical, deep cervical change, supraclavicular. 10. Supraventricular.
SPC, all right.
Alright? When you're palpating, remember location, size. They're usually oval if you can feel them, but most of the times you can't. Soft if they're hard, rubbery. If they're hard, rubbery, and non-mobile, it's probably cancer. Signs of inflammation, pain or erythema is usually signs of inflammation. Okay? Yes, I am. All right. All right. Thyroid posterior approach. A goiter. Remember, a goiter can be hypo or hyper. Not just a hyper gets goiters. It can be either or. Okay? We talked about what the hyper look like and what the hypo look like. Hypo, everything is slow. Hyper, everything is rapid. Okay? Facial examination, we talked about these already. Cushions, puffy, moon face, nephrotic syndrome, they usually have puffy swelling. Myxedema, they usually have like tough skin. Parotid enlargement, parotid glands are usually swollen. Acromegaly is big head. Parkinson's disease, usually you have mass species. Cranial nerves, remember your cranial nerves. They're gonna come and haunt you. Okay?
They never stop.
They always gonna come back and haunt you. Okay? All you have to remember. To touch and feel. On all Olympics, towering tops, A-fin, and German viewed some hops. That's the one. I forgot people were recording me. Okay? Always on all Olympics. On all Olympus. And remember, you always have to know if it's sensory, motor, or both. Some say Mary Bunny, but my brother says big brains matter most. I can't say that. We recorded.
I'm stopping it.